Hey everybody, welcome back to the channel. My name's Drew. It's awesome to have you here. I hope you're having a fantastic day. In this video, we're going to be looking at the levator scapula. It's one of our shoulder girdle muscles. It's also one of our muscles that's involved in our neck. And it's one of the culprits of a lot of neck and shoulder issues. And as we go through the anatomy and the functional anatomy, hopefully that'll come a bit more clearer why it's a problem. It's a really, really tricky muscle to treat. But if we understand the functional anatomy, we can definitely work with it. So let's get stuck straight in. As always, we're using Complete Anatomy. The app, I'm just showing you the surface level of what you can do with this app. So I highly recommend you go and get it. There'll be a link in the description. I'm not affiliated with them at all. I don't get any kickback from it. So I just like the app. I think it's a great learning tool. They do a great job. So here we have levator scap. So just kind of globally, it's sits on your shoulder, girdle here on the scapula, and then goes up the side of your neck into the kind of more the lateral aspect of the neck here. And it's an important movement muscle in neck movement and in shoulder blade movement. So let's have a look at the origin and insertion. Let's go back to info. Okay, so transverse process of C1, C2 vertebrae. So this is C1 here. This is C2. So these are your two neck vertebrae at the top, C2, C1. The transverse process are these bony protrusions or wings that come out to the side. This kind of whole part of the bone here is the transverse process. So we're attaching onto C1 and C2's transverse process. And then we're also attaching onto posterior tubercles of the transverse process of C3 and C4. So posterior means on C3 and 4, so C3 and C4 here, they're on the back part of the transverse process of the C3, C4 vertebrae. So that just means they're going to pull from behind a bit more. So that whenever a tendon attaches, where it attaches, what you do is you kind of like, you just visualize when the muscle contracts, it's going to pull in line to where its opposite attachment point is. So for example, if this muscle is attaching here and you can follow the kind of the muscle thread down, the fibers, what you'll see here is it kind of creates a bit of a twist through here. See how these fibers are rolling up and they kind of rotate. It kind of makes a bit of a twisting movement through there. So you follow that kind of line of the fibers, and what you'll kind of find is that it'll roll down to here. So when this muscle contracts, it's going to one pull on this vertebrae in a downward movement, and because it's on the lateral side, it's going to go pull down and to the side. So you're going to get a posterior kind of movement on the neck or an extension. So it's because it's going to pull back this way. And it's also going to have a lateral flexion movement on the neck that's going to pull this way. And so typically what happens, because it's going in two directions at once, you get a little bit of a quadrant or a two angles at once type of movement, okay, on a vector, if you will. So always just kind of like try to visualize where the muscle attaches to on the bones and then where it goes to opposite. So origin and insertion. So if we look at the insertion, it's going to be on the shoulder blade or the scapula. Okay. And this part of the scapula here where there's a slight angle, this kind of part here where there's a slight rounding angle to it, everyone's got a slightly different shape. Let's kind of see the here, it's a slightly angle. So that's called the superior angle of the scapula. Okay, so superior meaning above, and that's the angle there. And we can see this through here on the insertion, superior angle of the scapula, medial border of the scapula, superior to spine of scap. So this is the medial border coming up here. That's the spinal scapula here. So as you kind of cross the spinal scapula, it's kind of medial border, then kind of goes into the superior angle. And so that muscle kind of attaches that whole area through there. So when it's pulling, it's going to be pulling from the inside or the medial side and the superior side at the same time. So just kind of keep that in mind. Now, if the shoulder blade is fixed, as in like maybe you've got really good functional trapezius and rhomboids and lats and lower trapezius, and so your scapular stabilizers are really working well, and the shoulder blade is backing down. Okay, when this muscle contracts, if this section here is not moving because it's stabilized, okay, what's going to happen is it's going to pull on the neck, and you're going to get that lateral flexion, bit of rotation and extension, like so. All right, so you're going to get extension because it's going to be pulling down this way. Oh, sorry, bring it back. Extension because it's going to be pulling down on this line here. So that's going to pull the head back a little bit. Lateral flexion because it's going to be pulling this way. And then just because of the angle and the pivot point, when those two muscles kind of work together, you'll also get a kind of side tilt coming up like that on the angle. All right. Now, if the neck is stabilized and this muscle contracts, okay, so if the neck and head aren't going to move for whatever reason, okay, then it's going to then elevate the shoulder up this way. Now, when we go into motion, actually, let's jump into motion now, because it gets a little confusing. I'll explain what I mean by in a second. Let's get rid of all these other muscles. So we got fade. So in this movement, the shoulders are stable and the movement's coming from the neck here. This is lateral flexion here. So side bending, lateral flexion. Okay. So pause there. Let's zoom in a little bit. It would be nice if we could get rid of all of these, like actually hide all the other muscles, but we can't in this app. There are some kind of decisions they make in this app, like, oh, that makes things a little more tricky or difficult, but overall still amazing app. So shoulder blade is fixed. We're flexing the neck, and you can kind of see here as it flexes, you've got those 4 attachments and they spread out, and there's a rotation or a twist through them. See through here how you're getting this kind of twist, this rotation. Now this is the reason why a lot of people get into trouble with their neck and shoulder, because this is the first half of the problem, so the lateral neck flexion. And then if we go to scapular elevation, this is the second half of the problem. So muscle contracts, pause there, and so your shoulder is elevated up. Okay. So when this muscle gets really tight, because it's got this twist in it, this kind of torque, it can kind of get spasmed and it can kind of hold your shoulder up. Okay. And then it's also pulling on your neck to the side as well. So you can kind of get this posture where people have a shrugged shoulder or elevated shoulder and a slight lateral flexion and are jamming in here in the side of the neck. And that's not cool, because we're going to compromise all those nerves that are coming out of the side of the neck. Now, what also happens in this kind of pattern is we get this kind of, actually, let's go back to information. Okay, so we look at action here in the app. It says elevates and downly rotates the pectoral shoulder girdle at the acromioclavicular and sternoclavicular joints. Extends, laterally flexes the neck at the cervical vertebrae joints. So let's break that down. So elevates and downly rotates the pectoral girdle at the acromioclavicular joint. So this is the AC joint here. So that's the acromion. Sorry. That flat part of the bone there on the scapula. This is the clavicle. So the acromioclavicular joint, AC joint here. So what this is saying is when this muscle contracts, elevates, downly rotates the pectoral girdle. So when you've got to kind of visualize the pivot point is the joint. So the pivot point is going to be this joint here and the sternoclavicular joint, which is this joint here, where your collarbone meets your sternum, or technically that's the mandible there. Okay. So what's going to happen is this is going to lift up and this part's going to spin downward. So you're going to get this kind of downward rotation of the shoulder So you kind of get an elevation, but at the same time, the other side comes forward and down. So that's where you get that kind of pinning down. So and from the side, if you look from the side, what happens is as that lifts that up that way, so you kind of follow that line as it lifts it up this way. Okay. It's going to pivot here and here, and it's going to swing around this way. And so what that does is it dumps this part forward and down. Okay. So what that does, so when you've got the coracoid process of the shoulder blade slightly protracted and depressed down, okay, remember the muscles we've got attached on here are your bicep brachii muscle, your coracoid bicep muscle, and your pec minor. So two bicep muscles and a pec minor. And so they're going to tighten and pull this forward and down more. And so you get into this kind of internally rotated humerus, protracted shoulder and depressed down, and then an elevated medial superior border of the scapula. Okay, so that's going to go up, that's going to go forward, that's going to swing out behind, and that then typically lengthens your rhomboids and your lower trapezius and some middle trapezius, and they get weaker because muscles, when they're in a lengthened position, they're not as strong, so they don't contract as effectively, so they get weaker. And then these muscles up here compensate and they get tighter. And so you kind of get this kind of elevated shrug, but a rotated down and pinned shoulder. And in a lot of like supraspinatus issue problems, tendon tear problems, this is the pattern that evolves. And I had a client yesterday who had exactly this pattern, who is a truck driver. So he does 5 days a week, driving a B double, which is the big trucks with 2 big trailers. And he does basically Sydney to Melbourne, which is a big drive in Australia. So he drives down and comes back in 1 day, like the 12. Don't know how he does it. Anyway, so even though he says he has good 2 o'clock, 10 o'clock driving position, if you're holding that position, whatever hand's on top, that's going to be elevated, you're going to be doing that. Particularly over 10, 12 hours, you do that 4 or 5 times a week. And as he's describing his work role, he also had an injury where he hurt his shoulder 2 years ago. So in this particular case, what's happened is that the rotator cuff injury was there. The injury itself was treated, but it didn't resolve. They did a cortisone injection, which is a really good, like, a strategy in decreasing inflammation, but then you've got to layer in the rehab post that. But unfortunately, in this situation, had the injection, the shoulder, the pain went away. So he just went, I've got to go back to work, and didn't kind of follow through with a good rehab program. And consequently, he had that bit of guarding. And then when you add that guarding into like driving a truck for 10, 12 hours a day, 5 days a week, we came in here and this muscle was just so tight and it had this twist in it. And this shoulder blade was sitting up about 2 or 3 centimeters higher than the other shoulder blade. And then all those other kind of muscles that I was talking about, the middle trap, the rhomboid, the lower trap, they were all kind of weak. The upper fibers of the rhomboids and the middle traps work very tight pec minor and chest, a bicep inflammation coming down through here. So when I was palpating up through here, this bicep tendon was very, very irritable. It's the center spot for most people, but this one was basically, I'd suspect, early stages of the bicep tendinosis. So yeah, lots of things going on. And luckily in this case, there was no headaches, but often what can occur here is if you get this kind of pulling on that part of the neck, you'll close down those kind of spaces coming out through here, and that can kind of compress or compromise blood supply and nerve supply, so you can kind of get some kind of headaches generating from this area. So it's kind of occipital region through here. It's a very sensitive spot. But we managed to do a treatment. We released this muscle, but before getting this muscle, had to release the pec major, pec minor, bicep brachii long head, bicep brachii short head. We had to do a subscapularis release as well because that had tightened up. We did a upper trap release. We did a middle trap release. Then we did a lot of ART, active release technique, on this levator scapula. And then once that had kind of let go, then we did some kind of activation drills to kind of get the middle trap, the lower trap, at the tricep working, so we can get a little bit of shoulder retraction and depression. So not protraction and depression here. We want retraction and depression from the lower traps, not depression from the pecs pulling it down. Okay, so two different ways you can depress the shoulder. And we've got a follow-up session actually tomorrow, so we'll see how he pulled up. But we spent a lot of time just kind of freeing up this segment through here. Very, very tight. If you're doing your body work, massage therapy, and you get your hands on somebody, you will come across these. This is a very common presentation because this muscle, when it goes, it's just because of the rotation, the twist in the muscle, it just locks up, and then it's really, really hard to release on your own unless you kind of know what you're doing. You can stretch this muscle. It's a very technical stretch. It's difficult to teach people, and if they're already spasmed up, even stretching it's very difficult to do because it won't let go. You have to kind of engage in some PNF, some proprioceptive neuromuscular facilitation, which uses reciprocal innovation to kind of let this muscle go. So one way to do that, for example, is if this is tight here and it's doing lateral flexion, what you want to do is do resisted lateral flexion to the other side. So you would just put your hand on your head and just gently press against your head. That will engage this side. And so then there'll be a neurological feedback system that comes back, goes back to this side, and it says this muscle's trying to contract and bring the head this way. So we need you to let go and relax so we can move the head this way. Because if you don't let go and relax, then the head's not going to move that way. So there's a whole kind of very kind of nuanced, complex neurological feedback system, which will communicate to that muscle saying, hey, let go so we can do our job over here. And if this has been here for a long time, then this side will have been on stretch and these neck muscles will get weak as well. So it's this kind of complex feedback system that kind of like feeds into itself, and things just kind of stack and get worse and worse and worse. So the quicker you can get onto these kind of conditions, the better it is. And a lot of clients who I've worked with who've had shoulder or rotator cuff problems, okay, when this muscle's not being addressed, because of the way it lifts up the shoulder blade and it pins the scapula forward and down, they just keep getting their rotator cuff muscles jammed up here, and it's got nothing to do with the rotator cuff here. It's this kind of levator scap not letting go. So really, really important muscle to pay attention to, and to do some work with. And when you do, it is amazing. It really just frees up your entire shoulder. And yeah, highly recommend you learn how to stretch that bad boy there. So that's pretty much all I've got to say about the levator scap. Love to hear your thoughts on levator scap. Any treatments, any cool exercises, any tips, any tricks that you guys have come across, whack them in the comments. It's great to see people, you know, giving me their feedback and their kind of experience. That's always great. Let's really build a community where we can learn from each other. One thing you will know when you're in this kind of field, it's just ever evolving. You're always learning. There are new approaches, different methods. You know, it's not a one size fits all. As I was talking to my client yesterday, he said, so why would that muscle have done that? And I rattled off like 7 different possible causes. So one was his driving posture. 2 was old injury. 3 was stress. So anytime people are stressed, they tend to tense up. 3 was poor exercise technique, maybe doing something in the gym, in a yoga class, in a yoga practice that he wasn't doing correctly. 5 computer use, so you're sitting at a computer, monitors in the wrong position. Like I've got 2 monitors here, so if your prime monitor is the one you keep looking slightly off to the side, that's going to create tension in one side. So if you're dual monitor use, make sure you have your monitor set up for the primary one that's right in front of you, and your secondary monitor should just be one you're glancing to, not primary use monitor. Potentially any kind of like cervical injury up here, so whiplash, stuff like that. Maybe you hurt your neck doing something through here, and that can feedback and create that muscle to go tense through there. What else could cause issues in this one? And basically, you can also, is this injury called torticollis, where this muscle spasms and it locks up. And the worst case I've ever seen of that is I had a 16-year-old boy come in and he fell asleep on the couch in this position. Like he's just, how he did it, he like head fully turned to one side, slightly down, chin down, and he fell asleep like that. And when he woke up, he couldn't move his neck. He was stuck. He was stuck. He also had been working the day before painting. He was like doing a lot of looking up. So he kind of like had this double whammy. So when he woke up, he was stuck here. And I did a lot of manual treatment trying to release him, a lot of PNF, ART, acupuncture needling, stuff like that. And I just couldn't shift it. So I referred him actually out to a chiropractor. And chiropractor was able to kind of because what would happen is these joints would end range and they basically got jammed up and they wouldn't move. They got stuck. And I don't personally have the training to mobilize the cervical neck with manual techniques. So yeah, referred him out to a good chiro, and the chiro was able to do a couple of treatments to get that neck freed up. And then he came back to me a little bit later, and we did a little bit of rehab just to kind of restore the muscle function because it was still a little bit tight. So really enjoy working with good chiropractors and good osteopaths and good physios, because we've all got different skill sets, different methods, different approaches, different things we can do. And sometimes you come across a client where it's like, actually, that's not my skill set. That's not what I do. I'm going to refer you out. And, if they come back, awesome. But if they get sorted out with who you refer them off to, that's great. You're just building a great network. Clients really appreciate when you don't stop them around and treat them when you can't really do anything for them. And that word gets out. The best way to get referrals is to just do good work with people and don't be an asshole, and excuse the French, and then people will talk, and that's just kind of how you do things. Build up a good network, be honest, do good work, stay within your lanes, be open-minded, be humble, and just help people. Anyway, so that's the levator scap. Torticollis is the condition. If you ever get stuck in that position, I recommend a chiropractor and osteopath for that, who's got good manual techniques. You might be able to get it with a good remedial massage or some acupuncture. But when those end range movement kind of cervical segments are stuck, they get really stuck. You need someone who knows what they're doing to free them up. Okay. All right. As always, guys, my only ask would be to leave a like and a share. And if you have any questions, comments, or feedback, always put them down in the comments. And I'll see you for the next one. Not sure which next video will be. We've kind of moved up to the neck and the shoulders. So we might do the sternocleidomastoid next. That's probably a good one to look at next. Okay, so we'll see you for that one. Ciao.